Everybody, this is Erica Mello and Susan Clinton, and welcome to episode number 202. And this is a compare and contrast episode, I like to say, Susan. It's about two patients of mine who can't push, who can't do a push-up. We all have patients who can't push a door open. Pushes and pull are part of life, right? And so one particular patient had a very similar driver profile, but different reasons and different mechanisms as to their injuries. And one is actually one that you would not normally think about. So hope you enjoy this sort of interesting type episode. We talk a little bit about treatment, but it's really about, once again, thinking out of the box. And I also wanted to, we're gonna do some cross promotion of other podcasts that we find very valuable. And today's the first day we're going to do this. And there is one, it's Solange Ross and Deborah Chassie. They are both physical therapists. They're actually pelvic health therapists. And the name of their podcast is called the Franklin Method Fellowship Podcast. And we'll put the link to their show notes, to their podcast in our show notes. For those of you who don't know what Franklin Method is, Eric Franklin uses a lot of movement and imagery, and they're two physios who actually do use this method, in their practice to help increase strength and movement. And, I do a lot of Pilates to do that. And there are many ways that we can do movement. And so we just wanted to give you their link and, try to help cross promote and get more eyes on great content. So we hope you enjoy this episode, and here we go. Everybody, this is Erica Mello with my wonderful and lovely co-host, Susan Clinton, and welcome to episode number 202. Now, is this the first ones that we together since Boston, since CSM, right? I think it is, right?
First one done since Boston, and
wow.
If I'm not mistaken, this is the first one that we will be putting on YouTube.
Yes.
So,
Yes, hello. At least I got my hair done.
Right. As far as the video goes, we'll be putting it on YouTube. We've always put our audio on YouTube, but we thought we'd show up and say hi to everybody in person. So here we are.
Yes. So here we are. And once again, for those of you who are not physical therapists who listen to us, we were in Boston for our combined sections meeting, which is a large sort of group conference. And Susan and I presented on Tough to Treat, increasing your clinical expertise. And we had a great audience. And thank you for those of you who attended. It was lovely meeting everybody. It really was. And thank you for all your kind words. So as I mentioned in the intro, this is about two patients of mine, both male. One's fairly recent, one not so recent, but they can't do a push-up. And many people will say, well, I don't really need to do a push-up, but you need to push a door, and you need to be able, push is a part of life, even if you're pushing off like your chair, right? So, and there are many reasons why we can't do that, whether it's strength or a dominant movement pattern. So I'll give you the first guy's case history, very brief. And then I'll give you these other guys' history, also very brief, because we talked in Boston, Susan, about what set them up, right, and what kept them there. So
before you start into the case studies, I just have to say that, and I want to dovetail off of something that you said that's really important. Pushing is a part of life. Pushing is easier than pulling. So if people aren't pushing, I really wonder, why aren't they pushing? Because it's kind of a common thing that if you want to move something along, sometimes it's easier to push it than it is to pull it.
True.
Just a thought, not always, but sometimes, pushing is something that can be very have a big advantage to it. And it's kind of like, I'm interested to hear how this goes. I've already got some thoughts into my head as to I wonder if they're doing this and doing this. So let's go for it.
Yeah. So the first guy is, former military, doing sort of your traditional pull, push, like pull up, push up type workout, and complaints of mid back pain, so mid thoracic pain, and with a push up. Okay, so and a pull up, but I looked at the pull up, but the push ups is a little bit easier to get my hands on in terms of I can go on the wall with that. And prior sort of what set them up, what kept them there, prior injuries, as you can imagine, in the military, a lot of multiple rib fractures from jumping out of helicopters, former fighter, which is important to note. So a lot of sort of boxing and just general fighting as well in the ring, right? In the ring. And also has a history of bilateral, not elbow fractures, but he, quote unquote, bilateral elbow issues. His symptoms are both sides on his thorax, mid-thoracic. He feels a little bit of pulling in the left shoulder. So when you go on the wall, we talk about normal, narrow, wide. He is worse wide,
Okay.
worse wide. And the only other, he's had some foot problems like plantar fasciitis, old ankle sprains on his right side. So when he does a push-up on the wall, and his mid-thoracic pain it's left, but the thoracic pain is left greater than right. So he kind of spans his whole back. But when he goes into that wide base push-up, it's very much left pulling in the pecs, left pulling in the back. Okay. On his opposite foot, he has the plantar fasciitis, etc. So his main issue is the push. And I will just briefly tell you a very brief subjective, because I want to talk about the other guy and then compare and contrast. So in standing, his center of mass was way left. And I had him go on the wall to do a normal push, like a normal base of support push-up, and he was okay. We went wide, and I'm just going to show for the video. I don't know if you can see. We went wide. He went like this, starts off like this, and as he started to go lower, he went left and he went like this. Like there was medial compression of the GH and just a lot of pulling in his upper pecs. And when he came out of the push, in that full wrist extension, elbow extension, also symptomatic. So I put him on the floor. I had him grab dumbbells just to hold on to change the wrist pattern.
Mm-hmm.
And he felt better. So he wasn't in that wrist extension, elbow extension position. Felt better. Okay. Mm-hmm. I videoed his pull-up. When he goes and pulls up, pretty okay. When he goes down into that, meanwhile, we're in a neutral grip on the pull-up, and he goes into that elbow extension, way left. His whole body went way left. You could see it on the video. So his pattern, his dominant pattern, what kept him there, what the there is left. Okay, so that's number one. The second guy could not do a push-up or a bench press. So still push. One's closed chain, one's open chain with the bench press. This guy is an office worker, and he basically had, it was his sort of right shoulder pain, and he couldn't do, as I mentioned, push or bench press. He had an old clavicle fracture on his left side. So his center of mass, I did a similar thing, normal, narrow, wide on the wall, and also in standing, was way right. So both of these guys in their respective push-ups were loading their symptomatic side. Okay, loading their symptomatic side. So that, for me, and I'm curious to see what your thoughts are, that gives me an idea of their strategies for loading, which aren't optimal, right? I mean, why do they load? We think they load the opposite side, but no, these guys load their painful side, right? So what I find interesting with the first guy is that if it's a musculoskeletal region, or like the neck, the thorax, the GH, optimally, I'm putting my hand in air quotes here, the wider is better, is quote unquote better, because it gives the thorax and upper quarter ability to adapt. But this guy was way worse. What are your thoughts on that first, and I'll tell you what I think.
Yeah, without being able to see him, I'm
Yeah,
picturing a couple of things, especially the first guy that you demoed with the left shoulder coming up and medial
yeah.
compression of the.
Oh yeah.
So my question is, where were his hands on the wide? No, he was wide. Were they like this, or were they,
So
were they
so
straight?
I had him do this both ways, this way, and then I had him do this way. So
Uh-huh.
when he went wider, he was probably more this way,
Okay.
this
So
way,
he was
this way.
unable to do with his. He was unable to do.
He so he would do so the scapulo sort of like glenohumeral like scapula. He was like this. He couldn't go into that internal because he'd hike the shoulder up like that. Internal
Okay.
rotation.
So on the
So
floor, did you look at him on the floor without the dumbbells?
yes,
Was he able to keep his elbows by his side to go up in a push-up, or did he have to bring his elbows out from the side?
out,
Okay, so he wasn't
out.
able to generate a true military push-up is those elbows are in by the body and
Yes.
they're
No.
right in front of the shoulder, and their arms are not out. So he
So
wasn't able
yeah.
to generate any pressure or force to be able to do that. When you
No.
handed him the dumbbells, and was he able to keep his elbows in, or did they go
Yes.
out?
No, so he when I had him, I said just grab something so you can get a grip on something off the floor, so like a 10-pound dumbbell each. So just grab the dumbbell, and he was able to basically keep the elbows in, and he was asymptomatic. And I'm like,
Okay.
okay. And bear
Yeah.
in mind, the guy's former fighter, former boxer,
Yeah, so I'm,
multiple injuries to wrist and elbow.
wondering, so the thing that I'm wondering about, especially since he could do it with the dumbbells and keep his wrist straight, um, did he have any fractures of his hand?
No, I no, but I no, but the wrist and the elbow are significantly relevant here.
Yeah, I would say, I would almost even say the elbow is a victim of the wrist.
Yeah, because what right? I mean, fighters, what do? They tape their wrists every time they go into the ring, right? They're taping their wrists up. And he told me in his history, I forgot to mention this, sorry. He would wear elbow braces sometimes on both of his elbows because they would hurt. Like, okay, remember what set them up, what set them up, what set them up, right? And you're very perceptive because I think as therapists, we take a lot of this at face value, but let's change the environment. That's why it's like, well, can you do a push-up holding on to the, tricep bars or whatever? Just get your hand off the floor out of that wrist extension position
Mhm.
and elbow extension, and so he was able to. So you're thinking wrist. Why are you thinking wrist more than elbow?
Well, I'm thinking wrist more than elbow because I'm thinking that if I remember right from watching, and I'm not a boxing fan or a mixed martial art fan or any of that stuff, but you see them, you can't help but avoid the commercials. They're everywhere.
Yeah.
Um, but anytime I see that kind of thing, there's a lot of wrist flexion and internal rotation of the shoulder as they go to pound somebody with their fist. Um, when you squeeze something, if everybody wants to just take like a bar and squeeze it, there's a certain amount of wrist flexion that comes in, and
Yep.
there's it's a position that a lot of people don't think about that can lead to the radial nerve irritation where tennis elbow is, or the extensor brevis,
Hmm.
muscle point. And it has nothing to do with wrist extension, but it has everything to do with gripping. I'm showing this grip with my hand.
Yep.
And when you do that, there's a certain amount of tension that gets in there to like have to hold. And, and so if you're doing that and you're hitting over and over again, um, to me, that's going to set up the elbow problem.
Yeah.
And it's
Yep.
probably not an elbow problem. Was it more like the extensor, muscle tendons and the extensor brevis tendons and that type of thing?
Yeah.
Because when if he was able to grip around the dumbbells, then he was able to use his power. That's his power. That's his motor plan for power.
Yeah.
And
Yeah.
when he put his hands out on the floor flat he probably has very reduced wrist extension.
Yep.
then he has to like hyperextend his elbows or do something different at his elbows because he can't get the wrist extension.
Right. And even in the pull up when he was coming, so when he pulls up, he's fine. It's when he literally started to let go, like to go to the bottom, starting position
Mhm.
and full elbow extension. And not so much wrist extension, but the whole distal elbow and wrist, it's almost like nothing. There was something that was not elongating. Okay. Whether it
Mhm.
was nerve, fascia, whatever. Do you have any other questions or should I go
Go ahead.
continue? Okay,
Go ahead.
so I tried that. I also tried, just for our listeners, I have access to Pilates here. So I tried a grip. I don't know what you call those little mesh grips. I tried that just to change the input to the hands. I also had him, Susan, I should, the orange Franklin ball. Since we're going to be video, just give me a second. I'll show you. Um, these So these are Franklin method balls. And so I had him go on the wall with both. So I imagine I have one in this hand on the wall and do a push up. Same thing. So he's got a grip, this grip, same thing as the floor, much easier, wide, much easier because the hand, it was in a different position. And
Right.
I was like, okay.
So his motor pattern of power is with the wrist and extension and the fingers flexed, not
Yes.
a hyperextension of the wrist and the fingers flat. Did he
Yeah.
have trouble getting into that position?
Which position?
And like if you put his hand on the wall, did he have trouble getting into full wrist extension and with a flat hand? Or was he like
Yes.
he
Well,
couldn't
he could,
get there?
he could do it. He could do it, but like you could see the hand starting to do this a little bit,
Yeah,
the
yeah.
clawing,
So
and I'm
yeah.
like, but it was interesting. It wasn't the actual, like it was the push, but it was more though with a wider push. But as he's coming out, his non-optimal patterning was coming. It was when he was in that full wrist, even in full wrist extension, elbow extension. Even if you do just basically, I'm not even going to call this a median nerve, but something like this, he was really restricted.
Yeah.
Okay, and so for the listener, his mid back was his main issue. Yes, exactly, with the wrist, and so I think for him, so I did an investigation of his wrist and his elbow. He had a lot of tightness. It was like through the biceps tendon, the whole thing, the whole arm was so tight. And so I literally gave him, just really quickly for the listeners, I had him seated. So seated with his hand in extension, like he's leaning on his, like seating, and it's his left arm. His left arm is in extension, elbows in extension, wrist is in extension. And I had him just turn to the right to sort of open up or mobilize whatever the heck that was, right? I
Mhm.
did like 5 of those and it was significantly better. And so I was just something with that hand, wrist, elbow complex that is a secondary driver for him. So so I'm not going to go through the assessment because I want to get to the other guy, but his thorax was his main driver, but he had a secondary elbow, wrist, because of his history. What set him up, right? What kept him there was the boxing and a lot of the military, but he had those issues, and
Yeah,
that's
what
what
kept him there was
ultimately,
this.
the wrist flexion, exactly. It's boxing, right? Flexion, tape. You're
And
taped. You're fully taped.
yeah, the elbow's bent too, like, nobody goes
Oh,
straight out with their elbow when they
pretty
do that.
much.
That
Yeah,
power's there, right?
exactly. And so the funny thing is that I was going to say, oh, so when I had him do like scapulohumeral disassociation, like I had him once again grab the Franklin ball in one, the Franklin ball in the other, and just had him do this against the wall, much better. So just doing internal, external, like scapulohumeral disassociation, he was okay. He was okay as long as he was in that grip. When he was
Yeah,
flat on the wall, no bueno.
this is the same thing as somebody who is squatting, that their feet are curling and they don't have dorsiflexion. And
Mm-hmm.
so what do we do
Mm,
for that? We raise their heels up a little bit so that
exactly.
they don't have to go into full dorsiflexion because they can't. And
Yeah.
as soon as they do, their toes pull in and curl. So with him, it's the closed chain piece like this isn't gonna work if he's like this all the time. So,
Mm-hmm.
that exercise you gave him, yeah, it's a neural tension exercise. Of course it is. It's also just a getting him to rotate and move differently exercise. It's
Right.
introducing something that he doesn't do
Change.
dominantly all the time exercise.
Yeah.
And it's also with the arm down beside his body as a
Yeah.
beginner versus I'm sure you worked him up the wall at
Mm-hmm.
exercise. He's finally this way doing turns and stuff, to be able to
Yeah.
get all that in. But when you're like that for a long time and you've got the thorax that's kind of like pulling you into that position, that I'm not standing up here, but your arms are a little bit more flexed and your wrists, you're always kind of hanging in this position instead of, the other. It just, if you don't have the range of motion there and you've got neural tension there and you've got a really strong motor plan for power there, he's gonna have to spend some time pulling himself out of that and then
Yeah.
begin to strengthen around the new pattern. So it's not like you
Mm-hmm.
go from A
Mm-hmm.
to B and say, okay, just do your push-ups this way. It's like this is a start. Let's start getting your hand flat.
Mm-hmm.
Let's start getting the wrist mobility going. Let's figure out what's happening with the elbow. Let's get some of the shoulder external rotation in there and get you out of medial compression. Let's get the ribs
Mm-hmm.
moving. And let's see
Yep.
if we can't begin to bring you into a pattern to where on the wall first it works. And then we
Yeah.
gradually can incline him down to the floor. And then
Yep. Yep.
eventually he'll be able to do it with his elbows in. It's interesting that he doesn't have the power. And that's where that thorax driver comes in
Yep.
to push
Yep.
himself up at least partway. You would think you'd have the strength to push up partway before he goes into full wrist extension, elbow
Yeah.
extension. It's a little like, can you just get off like press this much off the floor?
Yeah.
But
Yeah.
with the thorax being stiff and being pulled to one side, it's going to be impossible with his arms next to his body to like do it, even though he could do it on the wall. Okay, when he
Yes.
was in that full closed chain posture down on the floor, he didn't
Yep.
have he wasn't able to generate the power because of the way that his driver was pulling him sideways.
Yeah, and it's interesting. So because both patients, I'll talk to the second guy in a minute, have the thorax was their main driver. But we talk about this a lot on the podcast that if you have a secondary driver, most people do as you get older. You're going to have more than one because of our compensations, but you will be limited as to exercise. Like I would have been limited as to upper closed chain exercise, or with the foot, you'd be limited as to upright exercise and standing if the foot's a secondary driver. Like this guy, his foot is a part of his driver profile, I would say, but his upper extremity is very, very intimately related with his primary driver, like his elbow wrist secondary. So but remember, listeners, it is, yeah, he has a history there, but as Susan so eloquently put, boxing, right? The guy's a boxer. I mean, you're taped and you're like you're flexed and you don't go full, like punching here. You don't go full into, I'm hypermobile into extension, so I probably would go into extension, but you don't generate power by a locked joint like that, right? And so don't dismiss their past movement history. That's what we talked about at CSM. Just, it is so important and it will cause you much less frustration down the road. And so, but I want to talk about just about an exercise program for both of these. So my second guy, I won't spend a ton of time on him. He's an older patient I've treated and discharged. But with his old clavicle fracture, he also has a history of low back, hip issues, sort of very active, but has a desk job here in New York City. But when anybody has had a clavicle fracture in their history, I put it on my magnet board. We talked about that at Boston, my magnet board, like it's an area of interest for me. And so why was my first guy loading his symptomatic side? I'm not sure, to be honest, but he had a lot of right lower extremity injuries, so maybe. But I do think, and he's a right-handed, so I don't know the answer to that. But he certainly centered out. He has centered out. My other guy was loading his symptomatic side. I think because of the old clavicle fracture, and so
The first guy had rib fractures, right?
yes,
Old rib
multiple.
fractures, so that could be why
Yes,
he was being pulled to
that's
the
correct.
right. And the second guy had a clavicle fracture on the
His
no, he was
opposite
being pulled
side.
to the left. Yeah. So the
Yeah.
second guy was being pulled to the right, but he had a left clavicle fracture. And the first guy also had that ankle, right
Yeah,
side
plantar fasciitis and
ankle,
ankle.
plantar
Yeah.
fasciitis. And so that, once again, I say this all the time, you've got to look at neural tension when you see heel pain. And this, you just
Okay.
described that first guy perfectly with the neural tension problems in his upper quarter,
Yeah.
and if
Yeah.
you've got tension through the system, it's going to pull on other parts of the system. And I
Yeah.
wonder
Yeah.
how much of his right plantar fasciitis was really right medial neural
No
tension.
tension. We did an episode on this, and for the
Yes,
listeners, just Google neural
we've done
tension, and yeah, a
several
bazillion
episodes
episodes.
on this.
Yeah.
Yes,
Yes.
the neural glides work so well.
Yes.
When
Yes.
it's
Yes.
like that, when it's not a tendinopathy and it's not a tendinosis and it's not, it's not a tendon problem.
Yeah.
It's, because all the other stuff they do for that doesn't work. So looking at the whole system up and down,
Yeah.
and the neural tension, can really, I think, make a big difference. But you see that integratively in this first guy. So now the second
Yeah.
guy, we have a left clavicle fracture. He's more of a
L-
desk worker. So
Yeah.
I'm picturing arms a little bit wide and hands dropped onto the keyboard and the forward,
Mm-hmm. Mm-hmm.
the dropped forward head. CT junction is what's coming to me right away with clavicle.
Mm-hmm.
That
Mm-hmm.
CT junctions have got to be stiff, at least on one side, if not the both sides.
Mm-hmm. Mm-hmm.
And so we've got a few things that are already built up in here. Plus, you said he's got low back pain and some other stuff, of course, right?
Yeah, left hip pain. A lot of the stuff was left-sided, left hip pain, left clavicle fracture. Don't dismiss. I mean, we've not done an episode on this particular patient, but I had an old patient years ago, left clavicle fracture. She had multiple injuries. Her clavicle was actually one of her drivers. Okay, so for the listeners, don't dismiss left clavicle. I mean, clavicle fractures, because they can be relevant in whatever your patient has. They may be secondary, but
Mhm.
in my experience, they are relevant because they will, depending on how active your person is, or even not. It needs to be investigated. And so his was rehabbed, quote unquote, he said. But when I had him do a bench, I had access to bench press back then. So he literally, when he did a bench press, his the barbell was higher, so he pushed farther on the right. So I'm lying on my back doing a bench press, and then my right hand is going farther, my left is not. Makes sense. Makes sense. His left side, his body's his right, the right push toward the path of least resistance, and that bound down clavicle is not going as far, right? And so what happens is he's translating his upper body to the right as he's doing a push-up. I don't care how good you are, when you do a load of 220 pounds constantly like that with a lopsided barbell, there's a problem. Okay. You're gonna eventually fail, and something's gonna break down, which happened to him. Okay. And so in terms of, I wanted to talk about the two of them, is because I wanted to talk about their exercise progression, because they both had push issues. They both were thoracic drivers, but one guy had the upper quarter neural fascial tension, and this guy had a clavicle. So how do we differentiate exercise progression? I'll tell you what I started off with, and Susan, you can add some thoughts. Even though pull-ups, push-ups are closed chain, you absolutely need to do open chain with these people too, because there's many ways that you can. These guys are doing push-ups. You get them on their hands and knees, it'll be a piece of cake for some of them, right? So I like to do we call it the scapulohumeral movement I mentioned earlier, just because I like the disassociation. But I also just I like to vary the input to the hands. And so especially when you're in that closed chain, I'll have them do things with the balls on their hands. I had them do a wall push-up, right? I had him do what's the word? When you're on the wall and both of your hands are on the wall, the first guy would be holding the Franklin method balls, or just a tennis ball or something for his input. And I had what we call a bow and arrow. So opening up, getting rotation in a bow and arrow. The second guy with the clavicle fracture didn't need the Franklin method balls because he was able to go full. His main issue was the imbalance in the reach. So for him, I would do a similar exercise there, but I would vary the use of the hands in a closed chain. I
Mhm.
also you talked about the clocks, to do like wall land clocks.
Yeah.
like right wall and clock. So I'll leave that. So you want to add any more closed chain? I don't want to. I mean, they were both very different exercise progressions.
Yeah, and I
Yeah.
think the bow and arrow piece is the one that, that you can do, and you can do it in so many different positions and postures to increase rotation. And of course, with the first guy, more neural tension. With the second guy,
Right.
just the ability to extend and push off of the wall on the one side,
Mm-hmm.
because it
Mm-hmm.
doesn't push as much on the one side as it did on the other.
Yeah.
So not treating the painful side, but treating the side where the movement pattern is
Mm-hmm.
not optimal for him
Yeah.
to do the things that he was doing, so he's overworking one side because the other side simply isn't moving. I see this a lot in people that end up with bilateral total shoulders, particularly reverse
Mm.
shoulders,
Oh,
because
interesting.
one is already not optimal, and it doesn't take long for the other one to become non-optimal,
Yeah.
because there's just too much connection across,
Mm-hmm.
that
Mm-hmm.
it just
Mm-hmm.
it does, the other one wears down or becomes quite painful, like this guy with the right shoulder pain, but
Mm-hmm.
the what was keeping him there? That left clavicle,
Yes. Yes.
so
Yes.
it's where it started,
Yes.
but it was also what was keeping him there, and then the other pieces that came on from that, like back pain and other things, just because of the non-optimal movement for, push-ups and bench presses that this guy wanted to do. He was overloading a side that wasn't a problem and became a problem.
Yeah. Yeah.
But it was because
Yeah.
the other was not working as optimally as it should. So,
Mm-hmm.
really being able to, I think, do that. But I also, for people who are, kind of trying to work, with, their hands on the wall or pushing on the
Yeah.
wall. And you talked about the clock. You can also, I like having them put, stand in front and like do designs on the wall
Mm,
and
that's
see
nice.
where it gets flattened, like draw a circle. And so they may be able to draw the circle coming out and coming over, but then when it comes time to draw the circle going the other way, they may have to like flatten it out, and then they can bring it out and
Oh,
come across, like the
yeah.
nearest position versus, the impingement position. They may come at it this way, but going back they can't. And
Yeah.
so
Yeah.
it can help expose, and they can start to think, okay, so can you make that circle smaller then, to where you can really have a full circle,
Yeah.
and but, use the shoulder and not just using, the hand coming back and forth, but really can you keep the hand still and use the shoulder to move it? But in this guy's case, both cases, well, no, the first guy for sure, can you do it with your hand? Like, keep your shoulder
Yeah.
still, and can you do, make the designs on the wall with your hand? Then you challenge by turning them sideways.
Yeah.
So
Yeah.
we have
Yeah.
the arm out to the side, doing
Mm-hmm.
it up. But they
Mm-hmm.
can there's always a bit of input from the wall, because you can keep the thenar eminence on the wall as they kind of move
Yes.
through their things. And those
Yes.
can become easy things to do. Just slide and glide up the door jamb at home, and when you go to lift something, can you slide across your cabinets a little bit, and,
Mm-hmm.
get some input done, and doing that. And does it feel the same side to side, which is nice with the wall, is you can make a circle with this arm, make a circle with this arm, make a circle together. Which one moves easier? Which one doesn't move so
Mm-hmm.
easy?
Mm-hmm.
Bring this one down, and let's go with what it feels like here. Can you,
Mm-hmm.
and let them get the input and the feel across midline and across their brain for a little homuncular refreshment.
Yeah, yeah, exactly. And I think, I mean, the obvious ones for higher level would be planks, chaturanga, down dog, things like that. But what's interesting is, so the clavicle fracture guy, his foot was a secondary, right, driver, and the set this the guy with the wrist and elbow hit less so. So for the the patient with the foot secondary, that needed to get treated, because I was limited in upright movement. So the center of mass issue was strong on both sides, but with my wrist and elbow person, the patient, what I gave him a center of mass exercise, because his foot was not, all he needed were for his foot was a quick ball release, and he was fine. It was a very small piece of the puzzle. So I literally put him against the wall, so both butt cheeks against the wall. I wanted him to feel the butt cheeks against the wall, get into a squat position, have a forearm wrapped around, I'm not the forearm, have a band wrapped around the forearms just to keep his center, get input to the thorax, and do side to side, keeping both butt cheeks on the wall. We know his left side, that's his path of least resistance. He got that. When he went to the right, you saw the stop. You saw the foot grab, actually. You saw it was just really interesting, Susan, because the center of mass needs to get trained. And in this particular guy with the wrist and elbow issues as well, that I felt I needed to do. More so him than the other guy. For some reason, because I like the proprioception on the wall with the butt cheek. Because the minute you find that one butt cheek's coming off, you're going into that rotation, and you're compensating, and that's not good.
Well, this guy number one had a driver on the lower body.
Yes.
And guy number two did not have as strong. He may have had a small driver on the lower body, but not as strong.
Right.
So
right.
that's why you would choose that. This is also where I talk about doorknob squats.
Yeah.
Because you can lean back, you can get the wrist straight, you can do them in different positions, you can hold on to some therabands around the wrist if you had to change them from holding on to the doorknob. But being able to have them use that as midline and come down, and maybe even target practice if they can only come down 90 degrees. Can you put something at 95 degrees underneath them? Can you just come down enough to touch that and keep this, as you're working with the foot? I find it interesting though. It would be interesting to see what this guy looked like in hands and knees with his feet tucked under. Not laying on top, but tucked under to help him establish that foot and that, and see how much that, was he even able, I'm kind of thinking reverse engineering this rather than him doing a push-up. If he's on hands and knees with his feet tucked under and he's strong, would he be able to lift his knees up off the floor?
That's a good question. I don't know.
Yeah, I wonder how he would look with that. It might be something you could kind of play with. And does he need the barbells in order to do it?
Yeah, most probably yes, but I will report back.
Can we put him on some blocks where he doesn't have to be in full hyperextension with finger full hyperextension? And can he begin to develop? Again, it's just creating, I'm just thinking reverse engineer the movement pattern a little bit for him.
Yeah. And I think just changing the environment, change something, right? I mean, the low hanging fruit was just take the barbells and just change your grip a little bit. But I also want, just circling back to the open and close chain, especially if the thorax or even like the lumbar spine, or even the neck is a driver, I like to put them sort of prone on a big pillow. So the thorax gets that input. So prone on the pillow, arms hanging off the bed or the plinth here, and just have them just lift their arms up in an open chain while their thorax gets that input. And that's also that gives that input for center, which is, can they just associate the thorax from the GH in like a prone arm lift? That's a hard exercise to do, but I want to see if there's compensations. I don't give that one out a lot, but it's one, if somebody needs that sense of center, that sense of that proprioception necessary to sort of configure their center. I did not do that with the guy with the clavicle fracture. Aside from the manual therapy that was done, with the second guy, I actually did a lot of so if we sort of reverse engineer, to use your terms, like this guy, when he was doing the push-up, his right arm was much higher. So I almost wanted to get him in a position where like I stood on top of him, right? And I basically just, put my hands on top of him. It was like a broom. It wasn't a really heavy thing, but I wanted him to keep it level. And I put something like attached to it, like one of those little things you put on to see the balance tipping. I just taped it. And I had him use that as for his vision. To watch the ball, and I want you to don't even look at your hand, just watch the ball. If you see that ball tip over, you're over recruiting, you're over pushing on that right side. And we talk a lot about vision in our podcast, and I almost wonder, especially with this guy because he couldn't do the bench as well, Vision does play a significant role, in I think anything at this point. But
Mhm.
the reason why I wanted to bring these two patients up was because they both had problems pushing, and I do think that even though push-ups are closed chain movement, number one, they both had different drivers in the sense that you have to clinically reason through what set them up, their background, what kept them there. They're both very different because that will give you the defining difference between the two and how you would treat them, right? And before I was going to say one other thing. Oh, and with the open and closed chain, you need to do open chain, you do, just to see, because even though, I mean, we need to do even if you do an air push up and you don't put your hands on the wall, you're going to see a similar compensation. So I think, because it's that push, that elbow with this guy, elbow extension, wrist extension. So I do think open chain needs to get put in there. A lot of people talk about specificity of exercise, but I don't know if I buy that anymore, because maybe as you go into higher phases of exercise, but I think early on we talk about variability and movement. You need to show their brains open chain, right, Susan?
Yeah. Well, and you think about the extremities have to do both. We don't walk
Mm-hmm,
around just doing
mm-hmm,
closed chain with our upper bodies. In fact, we do very little of it
yeah, for
compared to
sure.
what our lower bodies do, but our lower bodies need to do open chain movement. We need to pick our
Yeah,
foot up,
yeah,
look at our toes. We need to
yeah,
do these things. We need to kick something open. We need to step up on things and, move around and balance and one leg up in the air and, just different things. And yeah, the
yeah,
lower extremities spend more time in closed chain. The upper extremities spend more time in open chain, but they need both. I
yeah,
100% agree. And I think variability is the key. Look for where there's not, add it in, and then begin to load it and progress it
yeah, yeah,
under the whichever circumstances. Like this guy, the first guy, for it to be meaningful for him, he needed to work on what he was complaining about, the push-up. That was important to
yeah.
him.
It's a big
He got
deal. Yeah,
different positions, but it was relevant to him because you were working on what mattered to him. The other guy, it was the same. You were working, but you worked more with him in the beginning with the barbell and like the little dinghy hanging so that he could see that he was over pushing the barbell.
yeah,
That was relevant to him because it's gonna make my bench press better.
yeah, exactly. Yeah, yeah.
So I think that those are key things to keep in mind too, that if
Hmm.
you had taken guy number 1 and started just doing open chain exercises, he probably would have never come back.
Yeah, and I also wouldn't have picked up on the wrist and elbow,
Yeah,
right?
but I mean, but my
No.
point is that we've gotta keep it relevant to
Yes.
within the intervention and the clinical
Yeah.
reasoning, so, all
Yeah. Yeah.
right.
Yeah. Awesome.
Thanks, everybody. If you
Hope
have
you
any
enjoyed it.
questions, like and subscribe to our channel here, and,
Hmm.
give us feedback. Let us know how things are going, and
Yep.
anything you wanna add, Erica?
If anybody has any questions or wants to be, we still have an open invitation for anybody who wants to come in on the podcast. Our email is, for any questions, is tough to treat pt@gmail.com, and the website's toughtotreat.com. And for the neural tension issue that we talked about, the plantar fasciitis, type in heel pain neural tension on our website in the search bar, and a ton of stuff will come up.
Yep.
And
Yes, we have
enjoy.
episodes, relevant episodes. Thank you,
Absolutely.
everyone.
All right. See you in the next one.